Now we will spend a few moments to talk about the symptom control. That is something that is very important in palliative care. It's something that in our National Society for Palliative Care, we have the shortest course about symptom control is 2 days long. So you can imagine we cannot talk about all the symptoms and how we can control all of them now in one single lesson. But I will show you some principles, how you can start thinking, how you start solving the problems. We already saw this slide. It's from Up to Date, where there are collected symptoms, all the symptoms in palliative care in all different sets of incurable diseases. What is important from this slide is that you can see that everybody has pain, but all other symptoms are present in every kind of incurable diseases, maybe in a little bit different prevalence, but symptoms are present in any kind of incurable diseases. Important is that we have many, let's say, goals in palliative care. One is symptom management, family support. Very important is good communication. That's why we had an additional lesson on the communication, and even in the afternoon we will have the workshop about the communication. Then it's very important, continuous of care. Can you imagine what I mean with this? Continuous of care. I think I'm losing this.
Just let it go.
Okay. So continuous of care, what does it mean? In all phase, okay, that's one of the way of thinking.
And that you're available somehow for the patient.
Okay. Because when I started in palliative care, I started in tertiary oncology center. And I found out pretty soon that when I take care of a patient and he's feeling well, better, and I'm sending him home, somehow I lost control what is going on with him at home. And that is what I think we need to be in contact with GP, with the district nurse, to give them also the support so that we all together work with the patient, help the patient wherever he is. And if that patient will need in the future to come back in a hospital, it's the best way is to be in contact with GP and the district nurse and decide if he really needs a hospital or is that just a situation that can be solved at home. So that is what I think with continuous of care. Very important is the care in the last phase of life. This is just one part of palliative care, like we already pointed out. Very important part is supporting relatives after the patient dies. That's something that in Slovenia we don't have really good programs about that, but that's something that is very important for these relatives. And also in the field of palliative care, it was like 20 years ago, everybody was saying, oh, we cannot do anything in research in palliative care, it's not ethical. But you know, today we have a problem because of that, because we don't know, should we give them hydration or not? Should we feed them or not? You know, what is the best thing for the patients? In last 10 years, everything changed, and we are having more and more very good quality studies. And I just came back from European Congress about on palliative care in Madrid previous week. We were talking only about good quality research, and we have more and more information. So it's not only what my colleague, the old one, experienced one, is telling me, but we have really good quality research that we can, you know, stand on them and we say that's the right thing to do, and that's important. Also the education. Education, we have to spread our knowledge to our colleagues, because still there is something that around palliative care that we just somehow, that's not my problem, a little bit, but it is. It's the problem of all of us. Now we will focus on symptom control. And here you can see how is the symptoms developing during the last weeks of their life. And if you notice, their prevalence is raising up at first. And before we were like talking, Matteo was talking, when is the time, final time that you really need to think about palliative care? When these symptoms are accumulating and there is more and more hospitalization in a patient and he's breathing every time more difficult, then you really have to think, are we doing everything in palliative care way, you know? And if it is accumulating all the symptoms, this is the time that you need to start if you didn't start it before. And that is something very important as well. Last week of their life, most of the symptoms are reducing. You need to be aware of that, because some people are afraid that they are going to die in pain, you know, and everybody would give them even more and more medication for pain. Most people doesn't need more and more medication for pain. That's the topics that you are going to talk with Matea in our next lecture. So, before management of symptoms, it's going to be very like in a primary school right now, but that's not because I would think you don't know these things, but I just want to go with you through this way of thinking, the way of understanding the problems. But first, what we have to do when we have the patient. We talk to a patient and we have to do what about the symptoms? We need to identify them. Which symptoms do you think we identify first? What are fatigue? Now you already know this is not what we identify the first. That is what the most common. Dyspnea. Dyspnea. Why is dyspnea? You can already see from, usually, you can see that it's difficult breathing. What kind of symptoms we can notice quite easily? Vomiting, okay. Cachexia, yeah. Also some signs of pain, you can notice that. So we have to notice all these symptoms and always think a little bit broader. Not only one symptom. Don't be satisfied with one symptom. Look for the others. And we need to grade them. What does that mean? How do you grade pain? On a scale? Yeah? 0 to 10. And let's say, make it simple. How do we grade other symptoms? Let's say vomiting. How do we grade vomiting?
How often does it happen? Does it happen with
Yeah.
patients?
Do we have a scale for that? For vomiting?
For dyspnea, we have some kind of.
What kind of scale do you have for dyspnea? You are not sure. What about for fatigue? Functional capacity. There are a lot of scales in this world, you know.
There are subjective scales, but I'm not sure there are 4 graders.
But dyspnea is what? What kind of symptoms is dyspnea? Is objective or subjective? It is always subjective. So that doesn't. It's not important. Is it objective or subjective? We just need the information for the patient, how he feels dyspnea. So that's not in the case here. So we need to grade them. And I will show you a very simple way to do it, because everybody thinks, oh, we need to have some famous, I don't know what kind of formulary to do it. But you can do it pretty easy. This is Edmonton Symptom Assessment Scale. We translated it in our language. And there is about the pain on here. The first one is about the pain, 0 to 10. Why is it important that it is simple? Because even in your case, about the pain, you sometimes have a patient that cannot really tell you how pain is strong, right? But most of the patients understand that. And if you just say it, just do it the same way like you grade your pain, do it for the other symptoms as well. Just
Self-reported?
Self-reported. Self-reported for the pain, for the fatigue, for the nausea, and all this dyspnea, anxiety, depression, all those symptoms are here. And what is very important is down here. Down here, they completed, they filled in who completed it, or they by themselves, or someone helped them, let's say relatives, or sometimes our nurse helped them. Why I'm telling you that? Because it's very important who completed it. In more developed countries, these assessment tools, these ESAs, they use it in more, I would say, electronic way today. In Slovenia, we don't use it. We use it on a paper, and it works well. It works well, and the patient usually fills up the form before he came into my outpatient clinic. So usually I get the filled out form, and I already see what are the problems. And then he came in.
That's the first thing you can see.
So this is how it's done maybe in other areas of the world where the computers are on every corner. And I think this is our future as well. But I think you can start with paper as well. But important is that you know that it's really important to do it. What are our experience in my settings in oncology center? It was in 2002 that my colleagues started to think about this. How do we notice the symptoms? How do we grade them? And nobody actually knew about it. We knew everything about chemotherapy and radiotherapy, everything. We were focused on that, but we were not so careful about the symptoms of our patient. And they did a research in 2002, and they compare it with other results from other articles, international articles, and you can see the first numbers are from our center, and we have less pain, we have less obstipation, we have less dyspnea. Why do you think we have so? We are good, yes. I didn't want to say why we are so good, but okay, why we are so good.
You were not identified.
You didn't use diagnostic tools.
Yeah. Okay.
My opinion is better.
We are good. Yeah. No, but you need to know even why you are so good. You need to know why are you so good. If you are really so good, we are not so good because you need to know that we were looking retrospective in our charts, and nobody was mentioning symptoms in the charts. So the problem was that we didn't care much about the symptoms. And if you don't care about them, you don't treat them as well. So after that, the first research, we were like giving lessons around, and you need to write down, you need to identify, you need to grade, you need to treat them, and you need to write them down as well in the charts, And so in 2006, somehow we got worse. You would say worse. So actually it changed, and I would say that's not the change for the worse, but it means that we noticed the symptoms, and I hope we treated them better as well because we noticed them. So it's important to be aware of the symptoms. In 2007, we opened our department. It was a department with 6 beds, and we are still having 6 beds. And I am the one who always say we don't need them more, because we have a lot of palliative care patients in oncology center, and most of them are on the other departments. And I say in our departments, in our acute palliative care department, there should be the most difficult cases, the cases where I need my colleagues for pain clinic every day, because they are there every day. So the most difficult cases should come to us because we have the whole team who is focused on them. So other patients are on other departments, and if they need help, they can come to us. They just send some, I don't know, referral, and I go to the department and help them there. So that's the way we are doing. We have organized in our center. In 2012, we started also with outpatient clinic. That was supposed to be like a clinic for early palliative care. And in this clinic, like I said, every patient, at first they fill up this Slovenian version of ESAS, the questionnaire that I presented before. On the second side of this questionnaire is also this picture, and they just pointed out where the pain is. So it's much more easier to talk about the symptoms and about the location of the pain if they have time to complete it before I get to them. And this is a study from abroad where they were actually also asking themselves, is it important to find out all the symptoms? And this is the results of this. They did similar as we did. The first time they said, okay, that's the situation. They improved. And you can see that the symptoms improved much better when they were really doing regular checkups on the symptoms. And it was not that only, you see, much more symptoms were improved, but it was also important in the survival, because it was better for quite reasonable numbers. So they say it's not only about the symptoms that you can improve if you identify them, but that showed up also in the survival. And mostly they noticed that in older people, often in men, and the ones who were less educated, because those are usually the patients who come in to the doctor and they can be quiet, it's okay, and they forget to ask you questions. But if they have the formulary, they can fill in, they have time to do it. Or sometimes the nurse have to help them. So it's not only our experience in our institution, also other institutions are bringing up these results. How important it is that we find out what the symptoms are, that we can really manage them. So if we get back, we identify them, we grade them. We need to be aware of underestimation. What does that mean? You don't pick them up or something else?
Maybe they dissimulate,
Yeah.
they're not reporting real.
Mm-hmm. So the patient would dissimulate, yes, something else. We did a small research as well, and at first, in my outpatient clinic, everybody got this ESAS, that paper, and these were the results from this. The way they filled it in, and you see the pain, tiredness, drowsiness, all these questions from 0 to 10. These were the patients in outpatient clinic. Usually the patients in out clinic are in pretty well good shape. So usually they are walking by themselves, so they are pretty well. At the same time, we analyzed the same number of patients who were admitted to our department, and those patients are usually more weak. So what would you expect from the symptoms? More symptoms. But look what happened. At the department, we had more pain, but all other symptoms were less. Can you imagine why? You are so positive, all of you.
It was estimated by nurse.
Exactly, yes. You notice that the blue bar are filled in by help of the nurse, because patients were too weak to complete it by themselves in majority, and the nurse was helping them. And what happened with the information when there is someone in between?
Your perception is different.
You can imagine that how much pain do you have? Do you think it's 6 or 7 or maybe it's 3? Oh, it's more 3 because you see that it's not, it's your I don't know, influence. Yeah. So what do you think when we, after that we also looked in our charts for the same patient, the blue patient in the department, so the weak patient, and we looked into the charts of physician. How much symptoms do you think we write them down? You are not optimistic yet anymore, but you are right, unfortunately. Except, look at that. Why we doctors like pain? Because we have something in our hands. But you know, everything has, look, about the depression. Our patients are not depressed. If you ask us, doctors, that's not true. Yeah?
I think the pain is higher with the doctors here because the pain is often the reason for admittance to the hospital.
Yeah.
We have to have a reason to admit.
To admit, yeah. And the problem is actually in our minds, because when someone is admitted with the pain, we point this out like a first reason for the pain. Yeah. But that's why I'm telling you that it is so important to recognize other symptoms as well, because you can see there is so many tiredness. You see how much fatigue it was from the patient perspective, but from other perspective, almost none, or depression. This is terrible. It is terrible. That means that you would notice only the patient who came in and he said, "I'm so depressed." And you had to write it down, but otherwise we didn't even notice that. It's important. If you have a depressed person, you need to help him. What do you think? We didn't do that in part of this research. What would be the results if that ESAS formulary would be filled in with relatives? Difference? What kind of difference? Higher, huh? Yeah. But you know, sometimes I get into my outpatient clinic, I get filled in a formula, and there is everything 10, 10, 10, 10, so the worst numbers. And what do you think I do first? I looked at the bottom who filled it, and in majority is relatives. But do I have, is there any information for me, or I just can throw that paper away? And I said, that's...
Information that this family have problems with this patient.
Yeah.
And that's this very, very, very important information. No, but that is very important information. I'm always laughing as well, because it's like, 10, yes, of course, everything is 10. No, but that is really stressful situation for the family, and we need, usually that's the reason that we have to admit that patient, because we need to calm down the family, maybe just for 2-3 days, to do a family meetings or something like that, and to offer them support, that they feel strong enough to go on, to continue. So that's not such, not important, worthless information. But, okay, relatives. But just to point it out that it's not only in oncological center in Ljubljana that we are so poor, there are also other studies that show us similar. Okay, so we are now, we need to separate, to be underestimation, we already explained that. The next step is we need to separate reversible and irreversible symptoms. What does that mean? I use some a little bit unusual words, but still, what is reversible or irreversible symptom? Let's say dyspnea. We were already talking about.
Infection is the cause, it could be reversible.
For the dyspnea would be what?
Infection.
Infection? Something else? Yeah, effusion, of course. Cardiac, yeah, okay. So there are a lot of reasons for reversible and irreversible symptoms. And what would be irreversible? So something
Dyspnea.
for dyspnea.
Or it's fixing the change.
Cancer, metastatic spread of cancer that you cannot stop. Okay. So why is that so important?
Yeah, because you know, I mean, if you have an idea whether if it's a reversible reason, maybe it's worth trying
to correct it. Exactly. That's why I told you that I want to follow you through the process of thinking. Don't just say he's palliative care. He's going to die. Everybody is going to die one day. But till then, we need to do the right thing to do. And if there is a reversible cause of dyspnea, for instance, why not giving them antibiotics and he will be okay? Of course, if this is continuing, one day you have to, wait what is important for the patient. But if he comes for the first time with pneumonia, why not antibiotics, And if there is a fusion, there are a lot of patients in the oncological center with effusions, and you just let them out and they are fit again. So that is why it is so important to separate reversible and irreversible symptoms. And I pointed out here fatigue as well. Fatigue, what would be reversible and irreversible? Because we just mentioned that it is a symptom that is very common, but we don't want to talk about it because we think we cannot do much. I think so. But let us just think a little bit.
If it's like in the case that was born 2 days ago,
Yeah?
hyponatremia or something.
Yeah?
Anemia.
Anemia is reversible as well. Electrolytic disturbances, something else. Nutritional, yes. What else is also reversible? Also for fatigue, we can do something. That should be your message at the end of this talk. It could be sleeping deprivation. Could be, of course, a lot of reasons are for fatigue. And here you have like reversible and irreversible all together. And you can go through this, for instance, dehydration, also infection. If you treat that, they will get better. And then with some physiotherapy, they will feel well again. I mean, much better, not well, but. So depression as well. So always think, is there something reversible that we can improve? That's our task. That's our task in palliative care. Don't just think this is palliative. There is nothing else we can do. Always think what we can do. Always think about it. So if there are reversible causes, treat. If they are irreversible, okay, then you have to palliate. And here is something that is also important when you decide if it is already at that end stage of a disease. This is a SPICT criteria. It is an international tool that can be used everywhere. You can get it on the internet. It's free of charge to get it. And here is not only for cancer, but also for the other incurable diseases, dementia, neurological diseases, heart vascular disease, and all other incurable diseases that you can really, it helps you to make you, I don't know, that step to start thinking in palliative way, And the first question in this questionnaire is, do you think the patient in front of you are going to live more than 1 year? If you think that the patient in front of you is not going to live more than 1 year, then you need to think about palliative care as well, This is the first question. Okay, I finished, Maja. Now you can continue. If there are any questions, of course, now or later on.